I'm so excited to pull you away from the popularity contest out there, hot off your stadium tour. I'm Swati Patel, one of the GI doctors at University of Colorado, and we've talked several times now. So I feel very privileged to be able to pull you away. We are so lucky to have Professor John Byrne, who just presented hot off the press data on the things that truly impact our patients and can really prevent cancer in Lynch syndrome. So tell us the hot takes. What we're dying to know is, does aspirin work to reduce cancer risk in Lynch syndrome?
That's well, it's a great pleasure to be here, and I'm very pleased to be able to share the results of our trial. It's not published yet, so this is sort of, as you said, hot off the press. But I mean, I've been very keen to tell everyone around it about it who works in the field, because we need to get it out there, and the paper will come out in due course. It will get published through all the usual channels. But the bottom line is that I've been working on this now for 30 years, that we've known from looking at the general population that people who take a lot of aspirin seem to get less cancer. And so it was a logical question to ask is, well, what about people who've got an inherited predisposition? And we set up a trial first with FAP, which is quite difficult to do because they're younger and they get lots of polyps. CaPP3 involved giving people with Lynch syndrome 2 aspirins a day on placebo, and it worked, as you well know, and we reported that finally in 2020. But it's quite a big dose by modern standards, and we knew that, but we didn't want to give too little. But then we immediately started designing another study to compare that big dose with 2 smaller doses, the normal doses, if you like, of a standard aspirin or a baby aspirin. And so we've just got the results for that. And the bottom line is that the smallest dose had the fewest cancers. Now, I think that was a slightly lucky break. I think the truth is it didn't matter what the dose was. All 3 doses were basically tracking together, as you saw from the graphs. And the differences are probably just because you don't see a benefit immediately. The first few years, the aspirin hasn't kicked in, but from about 4 years out, the 3 dose groups were traveling side by side.
Yeah.
So I think the obvious, and we also know from our study where we blinded people, that the people who were given the smallest dose, not surprisingly, had the fewest side effects. And more importantly, none of that group ended up in hospital with a bleed, whereas we had 11 people out of the big 600 milligram group who ended up needing treatment in a hospital. So the take-home message, actually, remarkably, after all that time in 5 countries and many millions of pounds spent, is take a baby aspirin, it will cut your cancer risk. Now that opens up a whole collection of new questions.
Right.
How does it work? And I'll happily talk about that all day. The short answer is we're not absolutely sure, and we don't absolutely care. I mean, basically, if taking a baby aspirin cuts your cancer risk in Lynch syndrome, what's not to like?
Right. The science is exciting to understand the mechanism, but you're absolutely right. It's so critically important that this validates CaPP3, because there were, despite the high quality trial design, skeptics out there.
Sure.
And so in addition to the really amazingly practically useful data that there appears to be no difference between a baby dose aspirin, a regular strength, and that double dose, it sort of puts those naysayers away. It's been kind of frustrating clinically when we encounter patients who say, well, my doctor said that's just one study. And so here we go. We have validation of that original critically important work and this kind of next step of, as you said, many dollars, pounds spent to come up with actually the simplest answer. Baby aspirin does the trick. So I have a few practical questions. What age should we start this? Is this a conversation we should be having with our young adults even before they start clinical care with us in terms of colonoscopy?
Sure, that's a really good question. And I think the first thing I'd say before I answer all the obvious questions you're about to ask me is I'm not young enough to start any more trials. So what we have is what we get.
Yeah.
And the thing is that one of the things in medicine, and we've just seen from Julia, the international Delphi study, where we basically bring together the whole world expert community and say, okay, what's the best we can come up with to answer some of these sorts of questions? And as you know, we've now got a suggestion, a proposal, that everyone who's got MSH2 and MLH1 starts their colonoscopies at 25, which is how they always were, but we push it back to 30 or 35 for the genes with less severe stories. So given that we know from all of the literature, including our own study, that it takes probably 4 or 5 years before the benefit of aspirin becomes apparent, logically we should start 5 years before we start the colonoscopy. So we're recommending that basically, all other things being equal, I mean, obviously normally it'll be when people get diagnosed you talk about.
Right.
But in a bigger family where you know the story and someone's getting tested at 18 or 19 years of age, what we're suggesting is start aspirin at 20, and regardless of the gene, I mean, basically, the only thing is that if it's MSH, if you're starting colonoscopy in MSH6 at 30, which is the new recommendation, well then logically we'll start the aspirin at 25 and BMS2 will start it at 30. The harder question is when to stop.
Yes.
And I've already been cornered by some of my age mates who say, hey, why can't we keep taking aspirin? So there's two answers to that. First of all, there's a trial in Australia and America called the Aspirin trial where they gave people over 70 aspirin. And it didn't come out well. I mean, they got lots and lots of side effects and no obvious immediate benefit. Though you have to remember, you don't see the real effect for 5 years. So aspirin is only now maturing to the point where we'll see whether it prevented
the cancer outcomes, right?
But there was also a huge study done in California by Paganini Hill and colleagues where they went to the old people's homes and looked at their aspirin use and compared that to their cancer risk. And that was the only study in the 1990s that didn't find a reduced risk of cancer. So in that study, the people who were taking aspirin had more cancers. Now, that could be all kinds of biases because of observation, but it's also possible that as our gut gets older, it reacts differently. There's no question from all the cardiovascular studies that people in their 70s and 80s get a lot more side effects, which is why doctors don't like aspirin, because they see those people coming to the walls. The obvious answer is take the aspirin early, because the other great news from CaPP3 was that we only treated people for up to 4 years, and the benefit lasted for at least 10 or 15 years after that. Again, we don't understand exactly why, but the fact is if you take aspirin until you're 70 and then stop, you're going to see the benefit of that probably for another 10 or 15 years.
Yeah, that long-term protection is key, and so starting it early on when the side effects are quite minimal is an investment for the future, certainly.
I mean, the other thing I would say is you also get less problems with hypertension. So there is a big study from Sweden where they randomized people who had been treated for hypertension. So their blood pressure was all normal, and they followed a huge number of people, I mean, tens of thousands. And they found that the ones given aspirin were no more likely to have a big bleed inside the head, which is a very rare but very scary potential complication. Now, it's not caused by the aspirin. It's that about 1 in 20,000 people at all our ages, you have a little dodgy blood vessel in your head. It pops. If you're on an antiplatelet drug, it keeps bleeding, so the side effects are worse. But the thing is that in that study, normal blood pressure people, none of them had one of those complications. Now in fact, it was exactly the same rate. So what that probably says is that high blood pressure is a factor in that problem. And in fact, the only person in CaPP3 who had such a bleed, in fact, she didn't have any long-term consequences from that, but she had very high blood pressure, and they hadn't corrected it as we asked them to do. There was one other person who took part in the study who actually died of a subarachnoid bleed, but she wasn't on aspirin. She was 3 years off aspirin when she had her bleed and died. The fact is, people occasionally have this complication. If you're on an antiplatelet drug, it's slightly worse. But on the other hand, if you're in your 50s and 60s and 70s, your risk of having a stroke is massively reduced by aspirin because most strokes are caused by blood clots. So it doesn't say anything on the packet about that. So I mention it because it always crops up in conversation. But I think another way of looking at this is that if you actually look at the risks of colonoscopy, which all people with Lynch syndrome have, they're not zero. Occasionally bad things happen, even in the best hands. And we accept that very small risk, like we accept the risk of driving to the clinic. There are risks in life you just have to take.
You don't have to convince me. I absolutely agree with you. And, every intervention will have its risks and the conferred benefits, but that number needed to treat is just flooring, right? One, you treat 25 patients with aspirin to prevent one colon cancer. What other intervention can achieve that benefit? Incredible.
The other nice thing is, the question we're going to get back to is, why does it work? And one of the interesting ideas there is that, clearly, the only thing you're achieving with baby aspirin is to take out the platelets with these little blood cells in the circulation that plug up the holes when you bleed. And they've always been slightly neglected. They're kind of a bit boring when we're taught in medical school. We're looking at red cells and white cells, and the little blue dots, they're just platelets. Turns out they're really important. They're actually biochemically very active. And we know that when people get cancer, these platelets produce really quite toxic chemicals. And my partner in our new research program, Ruth Langley, is running a big other trial called Aspirin, where they're using aspirin to treat people who have cancer alongside their other treatments. And the great news is that it looks like, so another trial has just been published, as we heard in the talk from ASAP, they called the Alaska trial from Sweden, where the people given aspirin as well as their standard treatment did better.
Yeah.
And what's interesting is we're now looking at the tumours that are coming out of that. So I don't want to get into that story, but suffice to say that the aspirin is having an impact in ways that we never imagined. Yeah. And what we have to remember is that aspirin is the natural product. Our normal diet contains salicylates, and when we wandered around in the forests, whatever we could find, we got huge amounts of salicylate, which is the core of aspirin, from our natural diet. But when you eat, a fantastic breakfast here at the Hyatt Hotel, there's no salicylate in it anymore. It's all gone.
There's no plant-based.
Yeah, but even if there was good plant-based, the point is that plants that are not exposed to infection don't generate salicylates, because that's why they have salicylates. It kind of helps them protect themselves. So our natural diet has been changed and taken the salicylates out. And so aspirin's kind of putting back what we missed. And this little bit of aspirin is therefore, I think, almost a nutrient substitute, and defensible on that basis. But the interesting research that's just coming out on platelets is that these chemicals, one of them's called thromboxane, is released from platelets, and it actually directly inhibits the T cells which defend you. Now, we know that in Lynch syndrome the tumours are unusual because they're very, very visible to the immune system. And so if you take something that will allow your T cells to work better, they'll do the job for you and they will kill these cancers. And so we think that actually probably anyone with Lynch syndrome is getting cancer all the time, but most of the time they pop up, the T cells come along and take them down. And if you're taking something that will just make your T cells work better, aspirin's one thing, getting out in the sunshine and getting exercise is another. We know that your immune system is very sensitive to your general health. So staying healthy and taking baby aspirin, eating lots of fresh fruit and vegetables, get lots of high fibre, because from CaPP3 that the high fibre diet also was beneficial. It's kind of common sense really. Yeah. The only thing is that whereas high fibre diet and lots of jogging is easy to sell to the public health doctors, they don't really like the idea of giving people tablets. But I think in the case of Lynch syndrome, we're justified because they're already in a sense medicalized by coming in for their colonoscopies and so on. And this is a small addition, especially if it reduces the burden of cancer and reduces the likelihood they'll ever have an operation.
Yeah, without a doubt. It's just phenomenal kind of capstone to an incredible career and commitment to taking care of these patients over your lifetime. Practically speaking, in the U.S., we have a very diverse patient population. We talked a little bit about genotype and how you can kind of adjust timing of when to start aspirin based on genotype. What about other factors? In CaPP3, body mass index appeared to have a dose response. Did you observe any similar effects?
So we showed, as you quite rightly say, when this is what's called a secondary analysis, so you always have to be careful, but we went back and looked at body mass index, and the people who were overweight were 2 to 3 times as likely to get a cancer. But that effect was most obvious in the placebo group and less obvious in the aspirin group. Now that kind of fits in with this thing that having obesity as a health issue is a sort of pro-inflammatory state. And that's why we've always focused on the inflammatory issues. As I say, the fact is though that an antiplatelet dose of aspirin really isn't an anti-inflammatory directly. However, one of our partners in Italy has done some amazing work with experimental mice that developed polyps. And what she did was she took out a gene in the platelets called COX-1. Now, as you know, aspirin binds to COX-1, and that's how that stops the platelets working. And she did that to find out what would happen if the mouse was on aspirin. It's easier to just take out the gene than give them the aspirin, although we've done that, you can do it. And what she found was that these mice had 2/3 fewer polyps just by stopping COX-1 working in their platelets. So what we now think might be happening is that COX-1 is actually, when it stops working, in some way COX-2 is slowed down as well. COX-2 is the bad guy in terms of inflammation. And so we've always used other drugs to stop COX-2 working. It may be that just stopping the platelets will do the job
what that emphasizes is back to this thing about salicylate being a natural nutrient. There's all sorts of ways that aspirin affects our body, and we've got, the story continues to emerge. There are literally thousands of papers written about laboratory research on aspirin. And it's amazing, it's 125 years since it was released onto the world, and we still don't know how it works.
Yeah.
But the point is that it is working, it's cheap, it's out there, and so logically we should use it while we're thinking about how it works, rather than sitting on the fence for any longer. I mean, after CaPP3, as you said, there were naysayers who said, well, I need to see it twice, you know. I have to say, I was reminded when people started saying that, Sidney Brenner was talking about God inventing the universe, and he said he couldn't get a grant, you know, from NIH, because they'd say, well, he's only done it once, it's never been repeated. And he published it in an unrefereed journal. So I mean, the problem is CaPP2 took years. You just can't do these studies more than once.
Yeah.
And similarly for CaPP3, this can never be done again, because now the story's out. How do you randomize people?
Yeah.
So I mean, I'm really grateful to the nearly 2,000 people who did it for us.
Agreed.
And you know, the wonderful thing is, I mean, quite a lot of them dropped out because it's just too hard work. But 60% of them got through to the end of the 2-year blind phase and got rid of the horrible blister packs and things. But then we prescribed aspirin on the same dose, and they all stuck with us. I mean, all but 2, I think, stayed on for another 3 years. And you know, it's a not insignificant burden on them. They're taking the aspirin, they know there are some side effects, they're not sure if it's going to work, they have to be called up every 6 months, have to come for blood samples and stuff. So they hung in there, and you know, that was a tremendous team effort on behalf of the doctors and nurses and the counsellors and the patients themselves. And we've collectively, you know, got to the finish line. Except it's not the finish line, because, and this sounds like I'm asking for my next grant, which is true, because we now need to follow these 1,875 people for another 5 years.
We need the long-term outcomes in 2035.
That's right. So we've got to keep on going. And certainly for another 3 or 4 years, so we can really nail down the stats and be convinced, and also answer some of the questions that came up in discussion today, like, you know, what was the impact of colonoscopy frequency and so on, which is a very topical subject at the moment, and we will drill down on that. But in a sense, that's a secondary question. What's important is take an aspirin, you get less cancer.
Correct. Well, it's the definitive answer that we need for clinical care now. Every single individual has a pathogenic variant in a mismatched repair gene, Lynch syndrome, should be taking aspirin. Sounds like baby aspirin is the dose. Starting
the one thing, I just interrupt for a moment, the one thing is that the cardiologists in Europe have just published a huge study where they also got together on this question of obesity, and they said that for cardiovascular benefit, if you have a high BMI in the 30s, maybe 35 for sure, then you should take 2 baby aspirin to get the antiplatelet effect through there. So that fits in with our earlier study we talked about. So I think the sort of simple take-home message is, if you've got Lynch syndrome, 5 years before you would start colonoscopy, take a baby aspirin. If you're having problems with your weight, then it's okay to take 2 baby aspirins. It's still a tiny dose. It's only a half an standard aspirin. Some people say, can I take a half an aspirin? Yeah, you can. I mean, you know, but I mean, in America, 81 milligrams is so easily available. That's the logical thing to take. And take it from when you're young and stop when you get to 60, 70 to avoid most of the side effects.
Yeah, and confer benefit for the subsequent 10 to 15 years. And I think we'll see that when you look at the outcomes data in 10 years from CaPP3 also.
Absolutely.
So, thank you so much for sharing your expertise. You said that you've been on the stadium tour, and I'm glad that CGA was one of your stops. This is incredibly important, timely information for our patients here in the United States, so we appreciate you sharing.